Oturumu açıyorum. İlk konuşmacımız Allaire bize Torakoabdominal anevrizma tedavisinde dallı endogreftlerin güncel endikasyonlarını sunacaklar. Allaire, Henry Mondor Üniversitesi Endovasküler Cerrahi bölümünden bu konuda çok deneyimli ve araştırmacı birisi. Mr. Allaire, please.
I'm not coming, I'm running. I'm sorry for this delay. I must say it's an immense honor to be invited, and I thank all of you and the organizers and the scientific committee of this meeting. As Michael Jacob says minutes ago, I'm very much impressed by the high quality of what you're doing here. I must say also, I visit Turkey very often, and I love the Turkish literature, which is, I think, one of the best in the world. Now, I'm going to have a hard time talking after Michael Jacobs about the endovascular treatment the other way for approaching this very this very complex disease. Since the first attempts from Tutor, this stems already 15 years ago, the devices have made tremendous progresses. However, TAAA is a rare disease, so it means expertise, which means concentrations probably of cases in very few centers in the country. We face a tremendous burden of comorbidity of patients with sometimes a quite limited life expectancy. So the question is what we're doing for patients and at what cost. Sorry, I'm not, yeah. So we're going to talk about branched systems, branched stent grafts with conduit access from the main body to the target vessels for the 4 types of TEAs, but I will also mention EVAR as opposed to branched, which is used for subrenal or pararenal abdominal aneurysms and sometimes for type 4 aneurysms. And I will present the two because this helps to understand a few things better, I think. First, what's the first month of a patient after this kind of procedure? If we see for EVAR first, a very important thing is that the technical success is relatively high as compared to the complexity of the procedure. This means probably that mostly expert surgeons step into this kind of business, which means that probably beforehand it's very important to have a high training in rather more simple aortic procedures. Now, the 30-day mortality is quite variable if you look to the literature, from 1 or less than 1 to 10%. That makes a great difference. This difference may be due to patient selection. Shaggy aorta, of course, is not a good situation to put wires in the aorta, but also to expertise and concentration of cases in one center. This has to be kept in mind. The second thing I want to point is also that 30-day mortality is important, but probably in-hospital mortality is also to be considered, and sometimes it's much higher. So maybe 30-day mortality is a bit an optimistic view of the question. If you now go to meta-analysis, asking this question. You see this from Rao with a 4.1 month post-operative mortality. It's interesting because it's a comparison of FEVR and OR for AAA with no neck and type 4 aneurysms. And you see it's a lot of patients looked at. So I think it's a very solid view of what can be expected. Now, of course, this comparison with open surgery and endovascular surgery is biased by the fact that oftentimes the more frail patients get the endovascular solution, and Michael Jacobs has stressed this question also already in this presentation. Now, if we jump to the type 3 and 4 TEAAs, I think, well, this paper is very important. This is the Cleveland experience, and you see by the numbers the tremendous concentration of expertise. So the numbers is probably reflects what best can be expected. And you see that the 30-day mortality is 4.8%. And again, I think this stressed the importance to concentrate cases in one center or few centers. Now that was mortality. If you go to morbidity, then you jump to 40%, and that's enormous. This is, of course, open surgery carries a very high rates of morbidity, but we cannot say that endovascular techniques just ripped out the morbidity. It's not true. A very important question is paraplegia risk. And you see that for type 2 and 3s, permanent paraplegia is 4% in excellent centers. At the bottom of the slide, this refers to type 4 and juxtarenal aneurysms and the spinal cord injury risk. The total is low, of course, that's normal. But the very important thing is that the risk factor for spinal cord ischemia is coverage 3 centimeters above the celiac trunk. So this is a very important guideline to deal with this problem. Well, probably the most challenging question, in my view at least, is renal function. Again, this meta-analysis comparing endo versus open for juxta and pararenal, and you see that leaving the OR or the resuscitation ward, there's no difference between surgery and endovascular approach. That's the picture 1 month later. And this is for permanent dialysis, the same picture. Now with time, what we observe is that renal function degrades in the endovascular patients, and that's a preoccupation. And now you see a clear difference between open repair, in which renal function remains stable, as opposed to endo, in which renal function degrades. Factors are multiple, CTAs with contrast agents, of course, but that's not the only story. One very important question is geometry. The angle of the renal artery with the aorta varies from one patient to another, and the devices are not designed to take this into consideration. And the second thing is that the renal artery moves upward downwards with the respiratory cycle, and that creates strain on the renal artery and strain on the branches and injury probably of the renal arteries. That's a big problem. In France, we've been working for years with Cook, in which the branches are accessed from the groin. And I think this is a very difficult geometry, and you put a lot of strain on the ostia doing this. This is quite different for BEVAR, because you see that the branches are oriented downwards, so it's more physiological as compared to the angles of the renal artery with the aorta. But there are other technical solutions, and for instance, the anaconda system is, I think, interesting for this addressing this geometric question. You introduce the main body of the stent graft from the groin, but you cannulate the arteries from the subclavian artery. So it's, I think, more in shape with the anatomy. Plus, we have new tools. We have Torgid, which is an introducer. You can orientate from outside in the 3 directions of the space, so you can locate your guide wire just in front of the ostia. And I think this is very useful to avoid stress on the ostia when implanting the modules, the branches. Well, that's operation. Now, what happens years later? First, we must agree that FEVAR is very good at preventing death from rupture aneurysm or all-cause aneurysm-related death. For BEVAR, it's a bit different, but I don't think that surgery does better. But anyway, we must keep in mind that life expectancy of those patients is limited whatever. And if we put the cost in perspective, this has been to be thought, and depending on the resources of a given country. This is a very tricky question. What are the factors for long survival? Which patients are we going to select with probably a longer benefit of their surgery? Age, of course. Congestive heart failure is bad. Previous aneurysm repair is bad. And beware to cancer, as always, because we have to keep in mind that the second cause of death of those patients is cancer. Reintervention. Well, for FEVAR, it seems limited. For BEVAR, it's incredible. The reintervention rate is as high as 40% at 2 years. I think this has to be kept in mind too. Well, this is one of my patients. I'm not especially proud of it. The first operation was standard EVAR for a subrenal aneurysm, then type 1 embolic. So I made an extension to FEVAR, which is quite complex when you have the thrust uncovered to the visceral artery, and you have to put your branches through those thrust into the target vessels. But that this patient ended up with untreatable type 2 embolic. So I had to convert him to open surgery. Well, the good thing of the story is that I just had to clamp below the renal arteries because he had all the branches into the visceral arteries, so I made the operation quite simple. But that's a long story for one patient. And this is for FEVAR again. This is a composite, a criterion of everything is fine. No reintervention, no branch occlusion, no stent migration, no embolic, no aneurysm growth, no spinal damage. And at 4 years, you end up only with 60% free of any problem. That's the meta-analysis comparing reoperation for OR and FEVAR. And of course, you see the big picture again. Clearly, endovascular procedures still need re-interventions. Now, what about money? Well, if you go to rather simple endovascular procedure, such as fenestrated stent graft, of course, endo is much more expensive than open surgery. Now, if you go to more complex patients, type 2 and 3 TAAs, then there is no difference between OR and BEVAR, which means that, in fact, what is costly is the management of those patients, post-operative management of those patients. This is a study we made in France based on a registry for those patients. Now, in conclusion, FEVAR and BEVAR techniques are mature. However, I really think that tailored and new devices, more fitted to individual cases, must be on the market, addressing tortuosity, addressing movement of renal and visceral arteries during the respiratory cycle. This is needed. We need progress. There is a high rate of re-intervention, and this is particularly true for BEVAR. There is a major concern regarding long-term renal dysfunction. Costs are high, but as high as complexity. And we have to keep in mind that those patients have a limited life expectancy. Thank you so much.
Thank you very much, Eric, for your nice talks. We will discuss at the end of the session, okay? Thank you. The next speech is by Professor Samuel Bruls from Leeds University Hospital. Please, Bruls.
Sorry. Thank you, Mr. Chairman, dear colleagues, ladies and gentlemen. First of all, I would like to thank the organizer for their kind invitation. It's for me a very high honor. This is my conflict of interest. Endograft infection after EVAR or TEVAR is one of the most complex complications with a reported incidence between 1 and 6%. The management of endograft infection remains one of the most difficult challenges for vascular surgeons because of the heterogeneity of the clinical presentation, the comorbidities, and various available treatment options. Today's publication concerning infection after EVAR or TEVAR and 18 FDG uptake are consisting of small, simple center study with only a small number of patients. Furthermore, there are only 9 studies concerning the detection of aortic prostatic graft infection by functional imaging as FDG PET-CT. So, to our knowledge, this is the first study about the management of endograft infection by PET-CT. What's the value of the different imaging technique who can help in the diagnosing endograft infection? CT scan is generally the first choice for diagnosing prostatic infection, but the sensitivity is low in case of low-grade infection. Moreover, it can be challenging to differentiate normal postoperative change and hematoma from vascular prostatic infection. MRI, in case of vascular prostatic graft infection, seems to be more accurate than CT in graft infection assessment, but some limitation in early graft infection detection remains. However, FDG PET-CT offers better sensitivity and specificity than CT scan, 93 and 91 respectively. For a long time, through several investigations, our department has developed an increased interest for PET-CT use in aortic disease. Through this observational study, we aim to illustrate the potential clinical value of FDG PET-CT in the management of aortic endograft infection. During a 10 years period, 311 consecutive patients were admitted in our department for AAA, thoracic aortic aneurysm, thoracic aortic dissection, isthmic rupture, and thoracoabdominal aneurysm. All of them have been treated by EVAR and/or TEVAR. Among these 311 consecutive patients, 10 patients have presented in the postoperative course fever, increased white blood cell and C-reactive protein, alteration of general status, and positive blood culture. All of them have also suspicious sign of endograft infection on CT scan examination. So an 18 FDG PET-CT was performed for each of them. We observed a significant 18 FDG uptake at the level of the endograft for 6 patients, and the final diagnosis of endograft infection was now established. 4 patients with endograft infection suspected on CT scan had negative PET-CT. These 4 patients have presented poor clinical evidence and no proved infection at the level of the anevrizmal sac, as well as aortic endograft. They have been treated with prolonged antibiotic therapy from 1 week to 1 month with improvement status. They are the characteristic of the 6 patients who have a positive PET-CT. Most of these patients presented fever, pain, increased white blood cell, increased CRP, and positive blood culture. This slide summarizes the management, follow-up, and outcome of the 6 patients who have a positive 18 PET-CT, FDG PET-CT, 2 of them underwent open surgery for removal of the endograft and make arterial reconstruction and had a complete recovery. The 4 remaining had a poor risk and bad general status, so they only got conservative treatment with antibiotics. 3 amongst them died and 1 is still alive. I will show you some data during my next slide. So this patient is a 59-year-old man, presented fever and diarrhea with normal CT. Our colleagues, radiologists, conclude of retroperitoneal fibrosis. 2 weeks later, the patient on holiday in the French Riviera complained of abdominal pain, and the CT scan revealed abdominal saccular mycotic aneurysm. Three days later, he presented fever, myelina, hematemesis, and persistent abdominal pain. He was transferred to a university hospital in France. A new CT and a gastroscopy revealed the mycotic aneurysm with an aortoduodenal fistula. Considering the emergency, the patient underwent in France EVAR with implementation of a right aorto uni-iliac graft associated with a right to left femoral cross bypass. Conservative treatment was chosen for the duodenal, for the enteric fistula. 3 weeks after the patient decided for a transfer in our department in Belgium, we make 18 FDG PET-CT at the admission, and you can see that he was positive. You can see a high hypermetabolic infiltration around all the endograft, and despite good clinical status and negative blood culture. What can you suggest? Remove the graft or optimal medical treatment? We choose the optimal medical treatment with a combination of 2 antibiotics for a long time. This is the 1 year's follow-up by PET-CT. First, you can see an initial amelioration under antibiotic bitherapy during the 5 first month period, characteristic by less FDG uptake around the protesis. After this period, there was no further amelioration of the inflammatory parameters, C-reactive protein and Y blood cell increasing. You can see the 4 PET-CT image demonstrate a significant increase FDG uptake compared to the previous study, which suggested an evolutive disease. However, considering the absence of general symptoms, medical treatment was maintained. Moreover, after 1 year, this patient presented an episode of aperitic abdominal pain, and the 5 PET-CT revealed further progression of the peri-aortic inflammatory tissue around the endograft. Before any removal decision could be taken, the patient was admitted to the emergency room with a new episode of melena and anemia. The gastroduodenoscopy revealed a digestive hemorrhage in the duodenum caused by a perforation of the endograft. The endoprothesis and a part of the duodenum were both surgically removed, and an axillofemoral bypass was performed. During this time, the patient received an antibiotic treatment and hemoculture remained negative. After a 3-month hospitalization, the patient was discharged without symptom or antibiotic treatment. This is a second patient 3 months after EVAR for AAA. This 73-year-old man presented fever and alteration of clinical status. The PET-CT performed immediately showed increased FDG uptake, and because of good clinical status, the endograft was removed and patient had a full recovery. Another patient, 72-year-old man, who underwent EVAR in emergency for giant thoracic aortic aneurysm, presented in the postoperative course fever and alteration of clinical status. PET-CT performed showed high uptake and was correlated with CRP high level. After a period of antibiotic treatment, CRP level decreased in correlation with FDG uptake. But after antibiotics treatment, you can see recidivation of CRP according to the high FDG uptake at the level of the endograft. The last patient, a 70-year-old woman who underwent a TEVAR for thoracic aortic aneurysm, developed aortoesophageal fistula and underwent an esophageal prosthesis. Because of poor condition, patient didn't have surgery for removing the stent graft. You can see in the first PET-CT, despite antibiotics treatment, the patient didn't show normalization of the PET-CT FDG uptake. So conclusion, endograft infection after EVAR or TEVAR represent a diagnostic challenge. FDG PET-CT is an emerging imaging modality to establish an early diagnosis to assess disease progression, vascular complication, relapse detection, and treatment. Based on our observational study, our investigation postulates that FDG PET-CT represents a predictive indication of persistent infection when CT remains positive despite appropriate antibiotic treatment. Although there are positive results, the usefulness of FDG PET-CT for the diagnosis of aortic endograft infection had not been evaluated in a large series of patients, and large prospective studies are needed. Thank you for your attention.
Thank you very much for your nice presentation.
Konuşmacımız Katar'dan Doktor El Thani, Hikmet Medikal Merkezi Travma ve Vasküler Cerrahi Bölüm Başkanı. Please, Dr. Thani.
Assalamu alaikum, Mr. Chairman, Organizing Committee. I would like to thank you for the opportunity to present, and I would like to thank the privilege for the podium. My presentation is the clinical, pathological variety and aortic dissection in childbearing age. As you know, we have to think about the three components: risk factor, pathophysiology, and natural history of the disease. This is very important because women should be consulted regarding the potential risk, the outcome, and the treatment modality prior and during the pregnancy. I'll take you through the first case. The first case is a 32-year-old Qatari patient referred for me from her family physician because she is complaining of headache, and then they did the examination. They found that she had a bruit. Doppler ultrasound was done and revealed there is no pathology in the carotid. And she was referred to me, so I did further images, and you can see that she has a really tortuous carotid and unfolding of the arch. She's married and with 3 children, and therefore I had discussed with her the risk of further pregnancy. She has a family history of Ehlers-Danlos syndrome, so we sent her for genetic testing, and it was negative. So the good thing, she decided not to get pregnant. The second one is a nurse, 24 years old. She's athletic, and she's complaining of intermittent claudication. One day she presented with abdominal pain to the emergency, and they did ultrasound. And then they sent her to my office because she has aneurysm. The aneurysm is 4.5 centimeter. And as you can see, I did a further study which showed 4.5 centimeter aneurysm. But she has also a tight stenosis in the iliac artery. And this is a dissection almost. So I discussed with her whether there is a previous history of a trauma, and she denied that. She was planning to get pregnant because she had 1 son and she wanted further pregnancy. So we had a long discussion about treatment for this prior to her pregnancy. She agreed, and we went ahead with open surgery. And you can see the septa in the aneurysm there, and we put aort by iliac bypass. 2 years later, she became pregnant, and she delivered a lovely girl, and she sent her images to me. The third case is a known case of Takayasu disease, and she is a 26-year-old lady. She was referred to me because the blood pressure on the right arm is higher than the left arm. So we did a further study which showed actually stenosis of her left subclavian, but total obstruction distal, and there is also stenosis on the right side. But more interestingly, she had 5 centimeter aneurysm, almost dissecting, and she has a small kidney, and she's hypertensive. So her Takayasu under control, we discussed also this, and she said, well, when my disease is under control, I want to get pregnant. I said, wait, we need to fix this one. So we went ahead and we did actually endovascular stenting for her it was challenging because we had to go through the left common carotid artery in order to actually bridge that flap in the aneurysm. And a year later, when she said she's fine, I did a PET scan to see whether there is an inflammatory process in the stent site or any chance. And then we said, go ahead and you can get pregnant. So she was pregnant in the beginning of the year. And also last week she delivered a nice, lovely girl. And she sent me this picture. So I was very happy to her. The fourth case is a lady, 20 years old, had a fight with her husband and took the car and drove into actually a wall. She presented to the clinic, she brought by ambulance to the trauma center, and she had headache and abdominal pain. CT scan, although she said she's pregnant, we did a CT scan. She showed a frontal contusion, transection of the thoracic aorta, grade 3, and she had also liver injury, grade 1. But for her surprise and our surprise, she is actually twin pregnancy. So also we said we cannot actually keep you like this, and we went ahead and actually stent her. We tried to minimize the amount of radiation by shielding the uterus, and also this is after the stent and show the patency of the subclavian. We had to calculate the amount of radiation she received, which is very important for the long term, and document this actually for her and for her fetus. And the final case is the fifth case is actually a 34 years old, a married lady with 3 children. She had a blunt abdominal injury following a motor vehicle accident. She presented with dissection of the abdominal aorta, bursa fracture of L3, and also she had laparotomy because she has mesenteric injury which required laparotomy. For her bursa fracture, she had a repair. I didn't do anything for this patient because clinically she had pulses, and I just said, okay, since you are not getting pregnant again, we will just follow this one. And we followed her for actually 3 years, and this is the latest CT scan, slight aneurysmal dilatation, and the same actually dissection, but nothing else. So when we look at the pathophysiology of the aneurysm, we can divide them into degenerative, infective, genetic, traumatic, and inflammatory. The most important one is actually the genetic one, and the inflammatory and plus trauma in the young age-bearing group. The genetic one can be divided into syndromic one, like Marfan syndrome, Lewis-Diaz syndrome, and Ehlers-Danlos syndrome, and the non-familiar one is the familial thoracic aneurysm. The inflammatory is the commonest one is Takayasu, but we have Behçet's disease and inflammatory aortitis. Throwback registry, which is the registry of pregnancy and cardiac disease, which include 57 countries. They included more than 4,000 patients, and you can see the incidence of aortic disease involvement only 3%. In this study, the majority of these patients has Marfan syndrome, but also 12% had bicuspid aortic valve, and the rest is different completion. We know about Marfan syndrome that was actually described in the 1896, has main 3 characteristics: skeletal involvement, ocular involvement, and cardiovascular involvement. And it's actually described the genetic mutation in the 1991. And if we look at the literature for patients who actually had Marfan and delivery, we had 16 consecutive pregnancy. The main thing to look at is the risk of dissection is 6.5 in patients who are not receiving beta blocker, but mortality is 0, so it is actually not bad. Lewis-Diaz syndrome is autosomal dominant aortic aneurysm syndrome with widespread actually systemic involvement, including arterial tortuosity and aneurysm, hyperthoracism, and bifid uvula or cleft palate. And there are 2 types. Type 1, which is more aggressive, and type 2. And these are actually the genome mutation involvement in these, the TGF beta receptor 1 and beta receptor 2. In the pregnancy, the risk of rupture is high, and you can see it here. It's associated with 50% mortality if it takes place, as we can see here. And the main thing, the risk of mortality is due to dissection, and in this study, the risk of mortality is nearly 30% in type 1, 40% in type 2. Turner syndrome, most women actually infertile, but more recently with artificial donor osseous, they have become more actually fertile. And there is, in the literature, 138 patients who became pregnant with Turner syndrome, and there is 240 patients who became pregnant with artificial. But more importantly, these are actually at risk, 100-fold risk of dissection in comparison to the general female population, and they take place at a younger age when they are at the pregnancy stage. Of this all literature, we can see still the dissection is 1.2 when they are treated, and the risk of mortality for the maternal one is nearly 1%. The familial thoracic aortic aneurysm, it's actually, there is two main components, syndromic one with different mutation and non-syndromic one also with a different mutation. Ehlers-Danlos syndrome, we have actually in Doha a number of patients, nearly 25 patients, and run in one family almost with type 4 Ehlers-Danlos syndrome. It is a rare autosomal dominant connective tissue disease, and the genome is COL3A1, affecting the type 3 procollagen, resulting in clinical finding, imaging finding, and also genetic finding. The risk of mortality in pregnancy with this is 5.3%, and usually due to either third or fourth degree laceration, a preterm delivery, and life-threatening complications like aortic dissection, rupture, uterine rupture, and surgical-related complication. The congenital bifid aortic valve is the most common congenital anomaly for all the population. The complication with this mainly aortic stenosis, regage, infection, and aortic dissection. Takayasu, we can see actually in our part of the country actually some Takayasu, mainly in the Indian subcontinent group who live in Doha. It is a primary systemic vasculitis of unknown etiology, predominantly affecting women in childbearing age. The histopathological characteristics is a chronic inflammation, intimal proliferation, fibrosis, and degenerative changes. And there is clinical classification as well as radiological classification. We are all aware of these. The more important thing is actually the prognostic scoring for fetal outcome in women with Takayasu. It depends on aortic involvement, the start of the treatment, history, highest mean blood pressure, and the superimposed preeclampsia. A score greater than 4, and in our case it was 2 because we started the treatment early. She was picked up before the surgery, and she has only the renal and arterial involvement, which put her at a score 2, very low risk. And in the review of literature, there is 280 pregnancy with Takayasu, and the risk of maternal mortality is nearly 3%, and risk of fetal mortality is nearly 6%, with risk of spontaneous abortion is 15%. So what is the recommendation for these actually? Well, the recommendation based on the American Heart Cardiology and American Heart Association, patients with Marfan syndrome should be counseled about the risk of aortic dissection as well as the hereditary nature of the disease prior to the pregnancy. And it should be actually strict blood control for the patient. And also a close monitor for these patients on a monthly or bi-monthly with echocardiography to assess the size of the aortic expansion. Imaging should be actually MRA with avoiding the gadolinium component in order to decrease the chance or the risk of radiation for both the maternal and fetus. And the pregnant woman with aortic aneurysm should be delivered with actually a cardiovascular or cardiothoracic backup in the hospital. The fetal delivery, well, preferably should be a cesarean section based on the literature. And a progression of a disease during the pregnancy or prior to this may require a prophylaxis surgery for this. The size is important also. They don't follow the normal sizes. So for Marfan syndrome, greater than 4.5 centimeter, prophylactic surgery is better prior to the pregnancy. For bifid, aortic valve is close to or equal to 5 centimeter, prophylactic surgery. And for Turner syndrome is depending on the score of the aorta, which is greater or equal to 2.5, will require prophylaxis surgery. With that, I would like to thank you for the opportunity for the presentation.
Thank you very much for your very nice presentation. Zamanı çok açtık. 1 veya 2 soru alacağız. Salondan katkı ve sorusu olan var mı? Yok herhalde. Efendim bugün hem Mustafa Kemal Atatürk'ün vefatının yıl dönümü dolayısıyla onu rahmetle anıyoruz. Bu arada yine vatan için canını veren şehitlerimizi ve meslektaşlarımızı da hatırlamakta fayda var diye düşünüyorum. Katılımınızdan dolayı hepinize teşekkür ediyoruz. Bir sonraki kongrede görüşmek üzere.